Well, onward we go. We're going to move on to chapter 5 now. We're going to look at digital imaging processing, display, and data management. So this will flow nicely with what we talked about with our last chapter, but add some more details for you. So objectives, I'm going to let you go ahead and read through some of these. Okay, so digital imaging processing, we're going to have some little bit of review here mixed in with some new content. So our processing, we have various computer algorithms with their basically mathematical computations that are built into the system. Some of this could be AI at this point, and those algorithms are going to be applied to the digital data that we are producing and putting into those histograms, and they're going to work within that histogram to optimize the image for display. The digital imaging processing can be described in stages where we have pre-processing to prepare the data. This is all of our histogram work. And then we have this and default or post-processing, which include the computer operations before and after the image is displayed. And then we have post-processing, which is completed after the image. So pre-processing, like I said, that's several operations occurring. It's going to take that raw data and start to prepare it for further processing to display the image. Software corrections can account for imperfections such as bad or dead pixels. This is kind of works with that same idea that we talked about with smoothing, except the software corrections to work with imperfections is going to only work with imperfections, whereas smoothing is going to work with technique errors. Okay. These corrections only occur with digital radiography. One type, and this is an important type, with IRs is called flat fielding. And flat fielding, I always think about it as kind of like flattening the playing field or evening the playing field. So if it's detected by your software that there's non-uniformity in pixels, it's going to even that field and create more of a uniform level of intensity throughout the exam. So if it was recognizing that there's a lot of pixels that maybe aren't functioning on one end of your image and the other end is very dark, then it's going to apply flat fielding to even that playing field or bring that intensity to a more consistent image. The other thing in pre-processing, like we talked about, is the histogram process. So developing that histogram, we'll talk about it just a little bit more to help it get our image to where we. So here's an image of a histogram. This is, it doesn't specify which radiographic study this is, but we can tell that there's a white collimated area. We have some low brightness, some areas of brightness, lots of areas of grays, and then we have an area of no collimation or black covered. And so then our system is recognizing that probably this area was collimated off and probably this area was beyond the anatomy of interest and overexposed, and so it would set out my field of view recognition or volume or values or volume of interest recognition, and it would basically bookend this histogram, cut off everything that's outside of what it deems part of the actual image. Okay, that histogram or the data set includes all the pixel values that were sent over from that analog to digital converter, and those pixel values came from that converter after they were provided from the TFT or whatever the image receptor was utilizing. On our histogram, the x-axis, as you know, typically, although they can set these histograms up so they're not always consistent, so make sure that you're actually reading the histogram chart in order to be sure what they're telling you. But most of the time, the x-axis is going to be the range of pixel values, so this would be the numbers coming, or the shades of gray, whereas the y-axis is going to represent the numbers of each shade of gray. The location of the graph along the x-axis represents the image brightness and grayscale. And again, this is when you have to watch because sometimes they'll flip one side from high signal to low signal. So you have to be careful. So in this, we're looking, if I look at these particular values, 289 is a pretty low signal, so this is going to be my brights. 2817 is a high signal. This is going to be my blacks or my darks. Okay. This on my y-axis is telling me that I have very few bright whites, lots of grays, a whole lot of dark grays, and then I have this peak here in the very dark blacks, which would be indicating an area included on the image not covered by anatomy. Histograms errors we've talked about a lot of. We want to do everything we can do to avoid a histogram error. So we'll just very briefly go over that. One of the things on CR is that we want to make sure that if we are collimating on our imaging plate, that we are equally collimating all the way around our image. That we can get a histogram error that will look something like this. This could be the patient with the exact same technique. A, I wouldn't see anything. B is almost an ideal image, and that just comes from that histogram error. We talked extensively about histogram analysis, so we're just going to kind of bullet point this. If you have any questions, just let me know. So we know that our computer software is receiving a bunch of information from our analog to digital converter about intensities of pixels. Those intensities of the pixels are counted up and sent over to create a raw data histogram. Now, inside the computer system, the computer software has stored histogram models that we refer to as our lookup tables. And each of those lookup tables are going to have a characteristic shape of a very good image for that particular part of anatomy selected on my workstation. Then we know that we don't want to include a lot of the information that is not relevant to the volume of interest. So like I said, that volume or value of interest or field of view recognition is going to be applied so that all the brightnesses and the darknesses that don't seem to fit that volume of interest, the expected volume of interest, are going to be kicked out. At that point, that's when we're going to set the S max, S min, and S average. So our S average is to become our exposure index. So that's going to be the midpoint of my histogram, basically. The deviation index is going to be the recognition of the difference between where my raw data S average or exposure index was versus my lookup table exposure index. If they're right on the same, there's no difference, then of course you're going to get a zero deviation, no deviation from the target. If you're overexposed, you're going to get plus values. If you're underexposed, you're going to get minus values, demonstrating how far you are from the target. That's your deviation index based off of the difference between your SAV or exposure index of your raw data versus the SAV or exposure index of the lookup table. So like I said, the lookup table is essential here. This is that basically perfected histogram of what the perfect image of your selected anatomy should look like. The original pixel values can be altered to change the display of the digital image by really superimposing that raw data with the histogram, with the lookup table histogram, and then shifting the raw data to match the lookup table. When it does this, it's going to alter the brightness and the grayscale. So it's changing the window, it's changing the level as it does this in order to get those two histograms to align better. We call that changing and that realignment, we call that our rescaling process. So now some lookup tables might be represented as a straight line, others may be more like a shoulder curve. If the original image is altered, the original pixel values are different in the processed image, the graph would no longer be straight in alignment with its original form, but it would have a bit of a curve. So we can look at that here in a second. Say my original pixel values looked something like this in this nice line. it applied that lookup table, and that lookup table made it match this curved line, so it would change the shape of my curve here. I wouldn't focus too tremendously on that. I think you guys have a really strong understanding of lookup tables. This may muddy the water just a touch, but just recognize that sometimes you can see a lookup table that looks a little bit more like this than the ones that we have paid close attention to. So here's an example I think I showed on the previous slideshow, where we're seeing, you know, the chest lookup table versus the wrist lookup table, because the anatomy and the grayscales we're expecting to see on these two different anatomical parts is going to be very significant. Histogram analysis should maintain consistent image brightness despite a little bit of over or under exposure. And here we talked about this on the last slideshow, so I'm going to basically kind of just skip over that, but if you have any questions, let me know. Subtraction we talked about before. Here's an example of, this one is actually an example of subtraction. So you can see that you don't really see lungs, you don't see heart, you don't see liver or any of that. And so what has been done here is they did a mask, and then they tried to subtract everything that didn't hit, that wasn't a pixel value that was consistent with bone. So in this particular case, a little different than I explained in the previous slideshow, rather than subtracting everything that wasn't contrast, in this case, they found the value, the pixel value of bone, and then they asked the machine to remove everything that didn't match that particular value. So the only thing that was left was the bone. Edge enhancement, we looked at that on our previous image, so you can see it again there. Smoothing, we see it. Equalization, we reviewed that as well. Digital imaging artifacts, some of the things that we can run across would be those histogram errors. Here you can see that there is these little tiny little spots here. These are common little spots on a CR system when there's a speck or a lost area of phosphorus, or of the barium fluorobromide. If there's a scratch or a ding, then there isn't any capture element left, and then you'll end up with these brightnesses that are artifactual. Here we see some more artifactual images. Here, it would be a CR system that possibly was having a mechanical defect, so it kind of stuck and reread some lines more than once, and then didn't read some other lines at all. I can't remember exactly what we're trying to show here. Oh, here we go. This is an example of the Miore effect. So if you're in alignment with the grid, and then you're using a CR system, and that the CR laser is reading in exact locations that the grid lines would have subtly appeared, it enhances those lines, and we get left with this Miore effect. I mentioned in the previous lecture that they're a lot more careful about monitoring image display quality currently, and so the current image display recommendation, which you might want to take a look at some of these values, is going to be for a high resolution monitor or display, such as that in a radiology office or radiologist's office. You need a 5 megapixel display monitor for primary diagnostic interpretation. Now, our workstations are considered secondary, so we would not need nearly that many pixels, but these are what the radiologist's office has to use. They must also have a diagonal dimension of 54 centimeters or 21 inches, which is adequate for assessing a 14 by 17 inch X-ray. The pixel pitch of 0.2 millimeters is at a standard viewing distance about 60 centimeters or 2 feet is required. We'll go over some more of these requirements or recommendations later on, and it might be helpful to go ahead and start making a few note cards of just the really significant required. The display monitor luminance is going to have to operate at um, a luminance of 1 candela per square meter and a maximum of 350 candelas per square meter. So these are the luminance or the brightness that should be coming out of that display monitor. The ratio of maximum to minimum luminance is called the luminance ratio, and it's recommended to be greater than 250 on a display monitor with a luminance ratio of 350 will demonstrate improved contrast because it's going to be able to highlight more of those different shades. Windowing leveling, like we talked about, this is post-processing. You can complete this on your workstation, set your data back to raw data, and then the physician can window and level themselves. So windowing is going to allow more shades of gray. So this is going to expand the dynamic range or the grayscale that you're utilizing on that particular image. And so this gives us, you can see a lot better contrast resolution by widening the window. So if we widen the window, we lengthen the grayscale, we improve our contrast resolution. Here you can see they've actually widened it possibly too far to where we start actually looking like we have some noise on there. So this is something that should be used to the degree required and not beyond. Back to a little bit more about our computer systems. Our computer systems need to be capable of transmission, storage, and archiving. So one of the key components in making this possible is image compression. So our images are massive, take massive storage requirements. And so in order to be able to store the sheer volume of images that systems need to store, they have to undergo compression. So compression takes the data that's there and it compresses it to a smaller level so that it can more easily be stored and shared and that type of thing. Reversible compression means that there's no loss, or it's called lossless compression to the end user. So you guys all have experience with this, I'm sure, where you've taken an image on your cell phone and you want to send it to a friend, but you know it gives you 3 different options, large, medium, small, and you can tell how that the megabytes are going to be much less on the small than they would be on the large. However, if you send that small, when it gets to your friend, it may look very pixelated or not be very a very good representation of the image. We would call that pixelated poor image, we would call that lossy because we compressed it so much that we lost some of the information. If you compressed it to medium and there was no recognition that any of the information or the quality of the image was lost, then we would call that lossless. One of the things that is required is, you guys are well familiar with, is HIPAA. So HIPAA really drives the DICOM rules of qualities of a PACS system. So it's really going to drive some of the processes in a PACS system so that patient information can be anonymized and that patient privacy can be protected. There's other rules through HIPAA that require us to store images and data for years. So I think for adults, most images need to be saved for 7 years. For children, they need to be saved for 7 years past their 18th birthday. And then all of these systems have to have a disaster recovery process available and built into the system in order for them to. Teleradiology is just the term used whenever there's the practice of diagnostic interpretation outside of the facility or offsite. So if a radiologist is reading from home or from another country or from another state, that's all the use of teleradiology. Whereas telemedicine is the practice of practicing medicine from a distant site. So lots of times teleradiology is really common. Sometimes it will be just for a preliminary diagnosis, where maybe when there's not a radiologist in-house, they might send it to teleradiology to get a quick read on it, to make their decisions, and then usually it would be reread by an in-house radiologist later. Other times with teleradiology, sometimes it is done as the actual read. With teleradiology, it has affected the communication between the radiologists and the technologists, whereas before we used to have to carry the films in, put them on the screen, or excuse me, put them on the light board for our radiologists, possibly have a conversation with them regarding the image. Now we've really lost that, and so that need for communication between technologists and radiologists has changed significantly. And so the practice of teleradiology should be able to maintain that same high standards of safety quality as on-site radiology services. And if the lack of communication is significant enough, it would fail to do so and would not be a good alternative option. As with maintaining good quality control and security of our imaging equipment, like we've talked about, we also have to practice good quality control and security of our computer systems. So, a quality control is an important activity that should ensure the radiographic equipment is functioning properly, including the display monitors. So, not only are we going to end up having quality control activities for our equipment, but we're also going to end up having quality control activities for our displays, which I kind of started to speak about when I showed you the AAPM test tool or the SEMPTY test tool. Those are some of the things that we're going to have to use to evaluate our displays. There's going to be other quality control professionals that are going to be in charge of performing quality control of our PACS system, evaluating it for DICOM, making sure that all of the computer systems are, safe, secure, and professional. Policies and procedures must be in place and adhered to by all healthcare workers because we have access to patient health information. So this is very private information and should be protected very carefully. And so there has to be policy and procedures to ensure that that happens. You'll see once you're in the clinical site, those things can be easily, we can easily fail on that. So it's really important that we are trying to practice our best HIPAA policy and procedures and adhering to all of our facility procedures to ensure that we're maintaining privacy for our patients. One of the things that can be done, and this is usually in your PACS system, where there's going to be an anonymization option where we can anonymize an image so that then you could share it with us for critique, or it could be utilized in a lecture or something else. So we'd have that information, the data for research and growth in our profession, and yet we would not be compromising the patient's privacy in any way. The other thing is that you're going to see a lot of is authentication. So authentication is going to be when you have to use a password to log on to the HIS system, the RIS system, into PACS. Those are all going to be password protected, sometimes multifactorial protected, and that all, again, is all policy driven to save and protect patient health information. There's also very important basic firewalls, I would guess, within the different electronic systems that we use. Just like not every X-ray tech needs access to the patient's complete medical history, not every nurse needs access to all their billing history, and so on and so forth. So even though a computer software program may be capable of housing all of that information, there's really good firewalls and different things that I'm probably misusing that term firewall, but there's really good limitations to what a person's user status will allow them to see. So patient health information, radiographers, we have routine access to a variety of patient health information. We need to make sure that we're always following our HIPAA guidelines or the rules of HIPAA. Make sure that we're adhering to our department policies. You need to do that to protect your patient, but you need to do that also to protect yourself. Make sure that you're not sharing passwords, that you are not giving away more information, that you're not gossiping, things like that that could put your patient's health or information at risk, and as well as your career. So, okay, that wraps up this second part of our lecture. Thank you for sticking with me. We'll just keep going.